Fine.
Okay, so I'm going to be talking about anaphylaxis, and then Emma will talk about ALS, and then Kate will go through the other bits. So the aims and objectives, I'll just quickly run through. So it's knowing how to recognise anaphylaxis, being able to assess the acute patient and initiate basic management, including resuscitation, how to fill out a death certificate, which Kate will take you through, aware of indications for referral to the coroner, understand the purpose of DNAR forms, know how to discuss DNAR with relatives and the patient themselves, and consider how these could be potential OSCE stations. Okay, so scenario 1. So you're the FY1 on call for respiratory, and you get a bleep through. You ring it back, and the nurse tells you that Bob, a 68-year-old man with a community-acquired pneumonia, has just become very short of breath and is now musing at 7. So what are you guys going to do? Anyone? No? Whilst you're on the phone?
Where are they calling from?
Yeah, so the location of the patient.
Why is he musing at 7?
Yeah, so basic observations.
What does he normally use at?
What they normally use at. Yeah, so if there's been a change and they've been musing like that all day, or is it a sudden sort of thing? So the nurse, so exactly, location of patient, basic observations. The nurse tells you that basically she's really worried about the patient. They've suddenly dropped their blood pressure. They've become very tachycardic. It's just a sudden onset, and she's really concerned because she's just given them some antibiotics. So she really wants you to come and see them now. What do you think you're going to say now? Drop the saturations as well, so 70% on room air.
Have you stopped the antibiotics?
Yes, stop the antibiotics.
Can you put him on 50 litres high flow oxygen?
Yeah, basically it. So put the patient on oxygen, repeat the observations, and let them know that you'll be along straight away. So as you're heading towards the ward, what might you do in an ideal situation? They love you saying this in OSCEs. It probably doesn't really happen in reality, but anyone? So you might try and let your senior know if you've got their number or something. Just let them know that you're on the way and the patient might have anaphylaxis. Okay, so when you've already said this, but when you get to see the patient, what's your first thing that you're going to do is stop the cause. So if you think it's antibiotics, you're going to stop them from running. And then how are you going to assess the patient? Yeah. So do you want to run me through that? On the A, what are you going to do?
Talk to them, try to listen which ones they're speaking to you about freaking out.
Okay, so yeah, the airway's patent. Anything else you've been looking on the airway for the specifics to do with anaphylaxis? They've got a stridor. And if they had any signs of stridor, what would you be wanting to probably do? Bring the anaesthetist to see it. Yeah, so you probably want to contact an anaesthetist because they might well need to come along and intubate the patient. Okay, take that away. So the next one, so B, what are you going to want to know for that? Yeah? Yeah. Okay, so respiratory rate 35, oxygen stats. The nurse hasn't put them on oxygen, so there's 70% on room air. You've said you want to put them on high flow, 15 litres. On examination, you've got bilateral wheeze and reduced air entry. Oh, that I wasn't meant to put that out. So what would you want to give now if you think this is anaphylaxis? Yeah, and what's the dose? Okay, and how would you give this? IM, yeah, so not IV. So yeah, you give that. We'll move on to C. So what would you want to do for C?
IV access as well.
Yeah. Okay, so the blood pressures, they're hypotensive, the tachycardic, and they've got a slow cap refill. So what are these all signs of?
Shock.
Yeah. So as I said, you get IV access. Just heart sounds 1, 2, JP's raised, but you want to get some IV access, give them a flow challenge. For example, what might you want to give as a flow challenge? Yeah, that would be fine. We can give just saline as well. And then, would you want to give any other medications at this point now you've got IV access? It's been difficult to hear everyone. It kind of comes in this echo. Yeah, so how much hydrocortisone? 200. Yeah. And what's the other one? Chlorphenamine. 10 milligrams. So yeah, it's 10 milligrams of chlorphenamine and 200 milligrams of hydrocortisone. Okay, and then what would you do for D?
Regress.
Yeah, so GCS. Yeah, so GCS is 13 out of 15, and you would do the M as well. And then for sort of E, what might you want to just look for? Yeah. So yeah, he has a rash. Fine. Okay, so that's great. So then further management. What are you going to want to do after this assessment?
Reassess.
Yeah, reassess and
Document.
yeah. Would you want to contact anyone else?
Register.
Yeah, so you definitely want to be getting senior help at this point if you haven't done previously. So yeah, senior help may require transfer to ICU depending on how unwell the patient is. Further investigations that you might want to do, just in the general ABCDE, but
ECG, because you can do that generally.
yeah, ECG, yeah. Any others? So you want to do some blood tests. Do you know what blood tests are specific sometimes for anaphylaxis? Yeah, mast cell tryptase. The patient's very short of breath. What other things might you want to do for that?
What's the blood test for anaphylaxis?
Mast cell tryptase. ABG. Yeah, so you might want to do an ABG, a chest X-ray as well. Chest X-ray, ECG, ABG. Yeah, and you might want to catheterise them as well because they're obviously hypotensive, so you want to get a balance of them. Patients also had a wheeze on examination, so what might you want to do for that? So yeah, you could treat them like you would an asthmatic patient, so what nebulizer would you want to give them? Yeah, so back to that. And then another nebulizer as well? Okay. Very good. I will document reaction, which you already said, and inform sort of nursing staff, etc. This reaction time. This is the really boring bit. It's very brief. What is anaphylaxis? So it's a type 1 hypersensitivity IgE mediated reaction. It's commonly precipitated by, we've said one of them already, well, example, so medications. Other things that can precipitate anaphylaxis.
Like insect bites.
Yep.
Food.
Yeah. Things like nuts. Yeah. Symptoms of anaphylaxis.
Laryngospasm.
Yeah. It's edema. So edema. Like in the example, like shock, rash, and shortness of breath. There are more symptoms than that. Those are just I pick them out, the most obvious ones. And that's it really. Any other questions about anaphylaxis? Treating anaphylaxis. It's quite an easy one. I think it's come up in the OSCE. They've had it previously, and it sometimes runs into a sort of resus type situation. But just know those main medications. And that's sort of really the main thing. It's quite an easy one as long as you know what you need to give. So I'll pass it to you. And let's see what anything else now.
I guess the only thing that I have to add to Alice's excellent presentation on anaphylaxis is that post-anaphylaxis management, I guess, could come up in the OSCE as a sort of end viva kind of question. So you just need to make sure you say you'd observe and you wouldn't just send them home if they're at high risk. So if they're a known asthmatic or if they've had biphasic reaction before, then you can keep them a bit longer. You can give the antihistamines and steroids for 3 days. The steroids don't actually help in the acute phase reaction, they just help preventing the biphasic reaction. And you give them an EpiPen, some kind of patient education, and then they love you mentioning the yellow form, which is for drug reactions, which you might have seen in the wards. I'm just going to whiz through sort of advanced life support things. As I said earlier, the thing with this is just to practice it. It can come up in OSCE. They do tend to add it on the end of other things. So they've had anaphylaxis, I think, it hasn't been for now 6 years, so it could come up definitely. So as well as doing just the basic algorithm for ALS, I just thought I'd go through, make you think a little bit about what causes it. And in real life, it isn't as clear-cut as it can be sometimes in exam questions. So it's not suddenly that they have just arrested. You might be seeing people that are peri-arrest, and those are often a bit more scary. You don't have people around that you can ask what to do. So you just need to be thinking about things, common drugs and things that you can use in situations like that. So you can sort of classify them into probably differentials. So arrhythmias might be after they've had a heart attack or if they've got known heart disease already. Hyper and hypokalemia are things that they bang on quite a lot about at medical school, especially with tall-tension T-waves and things. They are quite important because they can be a common cause of cardiac arrest, especially in people that are relatively young. Bradyarrhythmias are another important cause of cardiac arrest, and those might be the kind of people that you see that turn up with second or third degree heart block, and you can do something about it before they arrest. Then you have your cardiogenic shock, so if they've just had an MI or if they've got advanced heart failure. And then your circulatory failures, which tend to fall into the categories of your H's or your T's, so things that you can actually do something about before they actually arrest. So 4 H's. Hypertension. Hyperthermia. I can hear a vague mumbling, so hyperkalemia, hypotension I've heard. Hypothermia. So hypoxia and hypovolemia. And then 4 T's. Yeah, I heard of it. So big P's, pneumothorax, tamponade, and toxins. So ventricular tachycardia is a common cause of heart failure. So you might get people that you'll see on the board that are having runs of VT. It doesn't mean that they are arrested and you actually need to act on it straight away with cardioversion, but there can be things that you can do to prevent them arresting. So the top one shows what? Yeah, and the second one? Yeah, and what's the common cause of torsical?
Drugs like antipsychotic.
What's the electrolyte disturbance that most likely causes it?
Hypovolemia.
Hypomagnesemia. So you treat it with magnesium. So for people that are having runs of VT, you can prevent them getting any worse by giving them amiodarone, which is also one of the drugs that's used in cardiac arrest. The problem with all the cardiac drugs is that they all begin with A, so if they come up in an MCQ, you can't just base it on the fact you know that that one began with a C or something like that. You actually need to differentiate between them, which is not very fair. So bradyarrhythmias, these are all the other types of heart blocks, so first, second degree, third degree. They might be asymptomatic. Which ones do you always need to treat? Yeah, so Mogus 2 and third degree heart block, even if they're asymptomatic. The other two might not need anything, but they'll either need a they'll probably need a pacemaker. And if they're hemodynamically unstable, then you can give them some atropine. So this is your ALS algorithm, which you've probably seen before. So it's just standard. You've been called to see a patient, the nurse says isn't moving or they're gone off or something. And so you go and assess them, say, can you get a response from them? If you can't, then airway, assess for breathing for up to 10 seconds, and then somehow let the ward, so probably you'll be by somebody you can press on the wall, and then the next person that comes, you can start doing compression straight away. The next person that comes, you get them to put out a crash call. So what would you, I'm not going to pick on him, what would you say if you need to put out a crash call?
Where are you? There's an adult or pediatric.
Yeah. Yeah, some hospitals like to say whether it's male or female, but you just need to say adult male crash call ward 29, and that's it really. So 2222. And if you're there first, you'll be the person that's doing the compressions. So you do it at a rate of 30 to 2, and then you ask anyone that's around to start putting the monitoring on, get the crash trolley, and you just keep going with the CPR someone will have a bag and mask to be doing the airway, and you don't stop to put the pads on. The CPR just needs to be continuous. You can then stop to assess the rhythm. What are your shockable rhythms? Yeah, so VT or EF, and then your non-shockable. Yeah. So see the top one for. Yeah, next one. They get the pulse. And bottom one. So we'll just whiz down the algorithm for a shockable rhythm. So that's your VF or your pulseless CT. So as I said, you've already got the monitoring at this point. If you're the first one there, you're doing the compressions. They've got quite a big drive at the moment about doing proper compressions. They have all the dummies that you've probably practiced on, which tell you if you're going deep enough, and they have this triangle that goes on top now that shouts at you if you're not. So you need to make sure that you do move around because you get tired quite easily. So you might have it on manual, you might have it on automatic. So depending on what setting you've got it on, it will tell you whether it's going to shock or whether you need to do it yourself. But just the key things with it is before you shock, so you take the oxygen away, you make sure that you're sort of taking control of the situation. So you say that you're charging, clear, shocking, and then straight away you go back on the chest for the compressions. That's the bit that's really important. People used to stop and check for the rhythm, but you need to go back and do 2 minutes of CPR before you start assessing the rhythm again. And you only stop to assess the pulse if you think that you've got some kind of organised electrical activity. So if you think it might be PEA, that's the only time you'd actually check for a pulse again. So that's what we said. So you do 3 cycles of that before you consider giving any drugs. And then the drugs that you use after the 3rd shock, once you're back on the chest doing the CPR, is adrenaline, which the dose is up there. It's 1 milligram IV if it's 1 in 10,000, and amiodarone as well. The adrenaline you can give with every other cycle. Amiodarone is just one off. I'm not going to go through what all the drugs are about. They're on there if you get the slides. So as I said, you can just give that every other cycle, and amiodarone is just a one-off. Non-shockable is the important thing with this is that you give the adrenaline straight away, so you need to make sure you get IV access, and then you recheck the rhythm every 2 minutes, giving adrenaline at the same time. So there's just a quick summary up there of the A drugs that we've already talked about. And then post-resus care is something that they can always ask you about. So you go back and reassess from the beginning, you do your A, B, C, D. The main thing with someone that's had a cardiac arrest is probably going to be neurological injury. You need to make sure that not PICU, not come from P's, normal ICU for adults involved, and that they take over their care. Any questions about ALS? A bit of all this through. So if resus isn't successful, then Kate's going to talk about what you do next, or how to avoid it in the first place.